It's now my pleasure to introduce our opening keynote, Department of Health Commissioner Dr. V.McDonald. For those of you who don't know him, Dr. McDonald was appointed Commissioner of Health on January 1st of this year and was confirmed on June 10th. Prior to joining the department in July of last year, Dr. McDonald served as the Rhode Island Department of Health since 2012. In Rhode Island, he served in multiple roles, including Interim Director of Health, Chief Administrative Officer of the Board of Medical Licensure and Discipline, Medical Director for the COVID unit, as well as the Medical Director for the Center for Customer Services and the Drug Overdose Prevention Program. Dr. McDonald earned his MD from Loyola Stritch School of Medicine in Chicago, his pediatric residency in the U.S. Navy, and his preventative medicine residency from the State University of New York. His diverse career includes officership in the U.S. Navy, as well as private practice in rural areas where healthcare shortages existed. His full bio is available on the conference app. I'd now like to welcome Dr. McDonald to the stage to provide his perspective on efforts to address racial inequities in health and the role of public health in empowering New Yorkers to live healthier lives and the role our industry, health plans, can play in supporting those efforts. So Dr. McDonald, it's really a pleasure to have you today.
Thanks, Eric. It's good to be with you this morning. Thank you for coming. What I'm going to talk a little bit about is public health this morning, and helping all the people all the time. It's interesting. I'm a pediatrician too. I've been a pediatrician for over 33 and a half years, and loved being a pediatrician. Still like it a lot, quite frankly. And when I think about being a pediatrician, as fun as that was, as valuable it was. Generally, as a pediatrician, I help one person at a time. In public health, we really do help all the people all the time. And I think that's just something that, one of the things I try to inspire my entire team about is just, we have a very noble mission at the New York State Department of Health. We get to help all the people all the time. And when I say get to, that's the operative word, is get to. We don't have to, we get to. And there's a certain privilege in getting to and a certain inspiration that comes from that. And today, it's funny, you're going to hear from a lot of speakers. And it's funny, when you hear from a lot of speakers, don't all the messages kind of blend together? It's kind of highly likely you don't even remember what people talked about sometimes. So I'm hoping you remember this one concept from me today. It's my firm hope, prayer, and belief that we want the same things. Your health plans. When you heard about what Eric talked about, we want the same things. We're trying to have a population that's healthy. And I'm going to talk a little bit about what that might look like, how we can get there, some ideas about that. But before I do that, I want to just tell you a little bit about myself. Quite frankly, most of you don't know me. I've gotten to meet some of you. It's interesting, as I've gone around the state and started running into people more than a few times. And it's interesting, I sort of joke with my wife about this. It's hard to get to know someone the second time till you've met them the first time. But it's funny how sometimes you just handshake somebody, a quick name, before you know it, the second time you have a deep conversation, third time you're working on policy together. So let's see what's possible together, my friends. But as Eric said, I've been around a lot of places, and it's kind of interesting. When I got in my Plymouth Horizon 5-speed in June of 1986 and drove to Chicago, Illinois to go to medical school, I didn't realize I wasn't coming home again until June of 2022. It's just interesting how my life brought me that way. Part of that was because the Navy paid for medical school, which was a wonderful thing for me, that I got to see the world at government expense, help a lot of people, meet a lot of, and learn leadership, quite frankly. The Navy's good at a lot of things. One of the things Navy medicine's really good at, though, is teaching leadership. I've practiced in a lot of parts of the country too. I kind of felt when I got out of the Navy, go where I was needed, hopefully wanted, but go where you're needed. So that brought me to central Pennsylvania, working among the Amish, the Mennonite, and other folks. Then I went to join the Indian Health Service. Who doesn't think that's a good idea, right? Let me take my beautiful wife, 3 kids under 5. Let's go move to the middle of nowhere and see what good we can get into, right? And Gail was on board. We had a great time. We then moved to rural Tennessee, ended up being a third pediatrician in a rural county. Came back here to do my preventive medicine residency, because one of the things I really learned was, although the Navy taught me a lot about leadership, really understanding public health, that was something I really wanted to do, understand public health. How do I become an expert in that? And went to other places after that, worked for the Department of Defense, the Civilian, the Rhode Island Department of Health. And then one of the things interesting about small state health departments is there just aren't a lot of physicians there. We had 4. No county health departments, just 4 physicians. So it gave me an opportunity to get a lot of deep expertise on a wide variety of topics and be surrounded by a lot of great people. And really, when I came here to the New York State Department of Health as the Office of Public Health Medical Director, it was really just for family. My mom's Alzheimer's was getting worse. So I wanted to be part of that end-of-life journey with her. My dad at the time was 91, healthy at 91, but not, he's 91. He wasn't buying green bananas, a little bit realistic about life. I have 3 kids, 2 have different forms of autism. And I just really said to my wife, we need to be around family. It's time to move home, so we did. And it was really quite surprising to me in some ways they chose me as commissioner, but I can see now why they did. Because quite frankly, what the New York State Department of Health needed, as I think about the baton I was handed being commissioner, is a pediatrician. Someone who works well with others, good at listening, very approachable, and understands prevention on very different levels. So it's kind of fun to be here, and I'm really glad to be with you today. And we're going to talk a little bit about how I approach situations. I think, since most of you don't know me, I think understanding a little bit about how does this guy actually think about things would be helpful. So the first question I ask a lot of times is, who gets helped? I think that's one of the most important questions because I think so often people ask, well, who gets paid? Oh, we don't always admit we ask that question first, but when you really look at what goes on, often we're interested more about helping the money move to people than the help coming to people. So I'm about who gets helped. Then I ask who gets paid. And I ask this question a lot of my team, is someone getting somewhere at the expense of someone else? It's always important to ask yourself, is someone getting somewhere at the expense of someone else? Because we have a history of systemic racism. We have issues of implicit bias. Everybody has it. That's why it's called implicit bias. But if we don't understand the question, if we don't willing to ask ourselves, is someone taking advantage of someone else, then you kind of miss sometimes some of the key moments that might be going on. When I'm working on something inside the department, I often ask, what's the work? And then I ask, who does the work? Because really what I'm looking for is the work what it is, and then what's the skill set I really need to do to accomplish the work? And then what I ask is, what's the public health value? Because if we're going to do work, if I'm going to find out who's actually going to do the work, it better have public health value. Otherwise, I'm not sure I want to do the work. And I think that's something you'd resonate with as well as a health plan. Is like, if you're going to do work, you want it to have value, right? And I do talk a little bit about public health messaging, and it's funny, as we've emerged from the pandemic, when you think about the pandemic, it was many things to many people, and most people have to figure out what their pandemic story is and was. I would submit to you the pandemic was an amazing population trauma, and everyone has a pandemic story. And you can tell your story when you're ready, but quite frankly, one of the things I think about during the pandemic was one of the things we did in public health, because it was a crisis, because there was so much new information, we were constantly telling adults what to do. But when you think about what we were telling adults to do, we constantly told adults 2 words: do better. Oh, it was needed, right? You gotta wear your mask correctly. We aren't supposed to see your nose, right? You're too close to other people, supposed to be 6 feet apart. We're on lockdown right now. You're not supposed to be at a bar. You didn't get the vaccine. You didn't go for treatment, and we kept telling adults to do better. And, I think one of the things anybody who's ever been a parent of a teenager knows is people don't like being told to do better. They just don't. Quite frankly, people do want, I think especially as Americans, we want to hear the why. We're rugged individualists. I've lived in different parts of the planet. Americans are different. We're rugged individualists. Tell us the why, we'll decide what to do. So my messaging strategy for the Department of Health is, let's explain the why, help people decide what to do. I think as a health plan, you'd resonate with that as well, because you have a population of people that you want to understand what to do. You can do health promotion, you want people to understand what to do. I often tell my team, and we're going to talk a little bit about health equity this morning, is, when you think about what's the mission of the New York State Department of Health, we really do want to explain to people what to do, help them decide, but really we're just a health equity organization, and we just happen to do public health. So I want to talk a little bit about our priorities, and it's no secret in public health we lost a lot of people. I haven't added up the years of experience that left the New York State Department of Health, and that was well before me. But it was centuries of experience left the New York State Department of Health. So I have to rebuild my department. I'm happy to say we're doing well. I have a wonderful, resilient leadership team. I have a wonderful, resilient team of professionals in the New York State Department of Health. We are rebuilding the department. In 2022, we hired 1,700 people, which sounds like a lot because it is a lot. 850 were external hires. Welcome to the department. Great to have you. 850 were internal promotions. Good to see your career advancing. But 850 people left the department for a lot of reasons in 2022. That means I ended the year 22 the same place I started. That's not what I was looking for. In 2023, though, we're seeing optimistic increases in our staffing. We're adding expertise, we're adding additional professionals, and every 2 weeks I get a report that shows we're adding, sometimes it's 8 people, sometimes it's 38 people, but we're adding people and our attrition rate's much lower. So I'm very pleased with how our department's growing. One of our other big priorities, by the way, is part of why I'm here this morning. I really value partnerships. I particularly value partnerships among people who want the same things as we do, right? Because partnerships are how public health works, right? And during the pandemic, a lot of things got pushed to the side, but partnerships were one of them, right? And the pandemic wasn't just isolating, it was individualizing. And that isn't always where public health works. Public health is very much a team sport. But our biggest priority at the New York State Department of Health is eliminating health disparities. And I worry when I say eliminating health disparities, people think perhaps I'm naive, or perhaps you think it's just hubris. And you know, I would actually submit to you that if the commissioner of a state health department isn't committed to eliminating health disparities, isn't willing to say, this is our North Star, then no one else will be. And I hope you'll join me in saying, yeah, we need to eliminate health disparities. And by the way, eliminating health disparities is intentional work. It will not happen if we're not willing to change what we do. And I think it's important to just understand leadership is about a lot of things, but one of the things I learned a long time ago about leadership was, Jim, you can have all the plans you want, but that just doesn't always work every day, right? One of the things I learned a long time ago was it was the tyranny of the urgent that interrupted the significant and the strategic. So if I want to do something significant strategic every day, daily leadership was about managing my tyrants to accomplish something significant and strategic. So every day, I get confronted with the oddest little tyranny of the urgent moments. I promise you, as a health commissioner, it's amazing how every day the sky appears to be falling, yet every day it doesn't. Part of that's having a great leadership team. But I tell you, that's one of my little secrets of leadership is managing my tyrants. I'm going to give you a high-level view of my department, by the way, though. I think it's important to understand, how do I think about the New York State Department? We're different, by the way. We're the largest payer in the state by a lot, aren't we? Right? We have a lot of money. When we belly up to the budget table, we're half the state budget. That's kind of a lot, isn't it? Like, there's only 7 state health departments in the United States that Medicaid is part of their state health department. And we have the essential plan too. This is us. This is good, right? Because by the way, when I want to go talk to the folks who run Medicaid or run the essential plan, I don't have to make an appointment and see if they're willing to align their ideas with my ideas. I know Amir. I know Danielle. I know they're aligned. We can text and we can have chats and we can be on the train together. In other words, they're part of my department. It's a lot easier to align people that are part of the same organization. One of our other things about us is we're a large health regulator. We regulate hospitals, nursing homes, physicians. We do a lot of regulating. You know, the other thing though is I have a huge public health mission. Oh, I have a huge world-class state health laboratory that's part of that. I have some direct patient care in veterans homes. We even run a hospital. We have a huge public health mission. We touch every New Yorker every single day in something that we do. Most people don't know it, and quite frankly, don't need to know that. So my job is to align all of this so we eliminate health disparities. And this is why I remind my team often, we're a health equity organization that just happens to do public health. You might be too, by the way. You might be a health equity organization that just happens to do public health. Oh, you may look like a health plan, but you could be a health equity organization that happens to do public health. Think about what you do, right? So talk about some other things, because other state agencies have public health functions too, right? You know, the Center for Disease Control and Prevention actually put together, what are the 10 essential public health services? You know, which is interesting, but you think about all these other state agencies, it's not hard to say, well, gee, state education does provide us with a social determinant of health called education. That's a pretty big job. Our state education department, though, is responsible for a core public health function, providing a skilled, diversified workforce. But you know, if you think about Office of Mental Health, they have a huge public health mission too. Same with Office of Addiction Services and Supports. Same with the Office of People with Developmental Disabilities. So many other state agencies have a public health mission. In other words, public health isn't something at the New York State Department of Health that we think we have a corner on the market. Quite frankly, it's just the opposite for me. Kind of view anybody who's willing to be a public health ambassador, because quite frankly, it's a team sport. One of the things about public health, by the way, is it is public. So I'm even happy if the public wants to participate with me as well. I chat about some public health terms that are near and dear to me, and I hope they're near and dear to you as well. And the terms I'm about to use, quite frankly, I fear sometimes people use these words, but they don't really know what they mean. So I'm going to give you the New York State actually define these definitions in law, but I'm kind of going to give you the V.McDonald version of them so you can remember that, right? Because I don't know about you, but every time I read a law, I look at how artfully it's worded, how beautifully it's crafted, but how hard it is to remember, right? And health equity is actually defined in New York State, right? Put the definition up there for you so you can read all that. It's a beautiful definition. Achieving the highest level of health for all people shall entail focused efforts to address avoidable inequalities by equalizing those conditions for health for those that have experienced injustices, socioeconomic disadvantages, and systemic disadvantages. I doubt when the governor signed that law and the electeds put that law together, they were saying, well, it's never going to happen. It's just aspirational. I doubt that was the intent. I think this is what people really want. But when I think about health equity, what I really think about is it's really meeting people and meeting people's needs where they are. And if you're going to meet people's needs where they are, you're going to achieve health equity. And by the way, if you're going to achieve health equity and meet people's needs where they are, that's intentional work. In other words, it won't happen if we just keep doing the same things over and over again. Health equity work is intentional, and everybody has to intend to do it in order for it to work for all of us. So now that we've talked a little bit about health equity, let's go on to another topic, which is social determinants of health. It's interesting how this term has become more and more popular in our lexicon. I remember learning about this in graduate school, social determinants of health. It was mind-boggling to me. Keep in mind, when I did my graduate school at the University of North Carolina, did my master's of public health, I was like 15 years into my career. I thought the exam room was the only place you could actually create health. I know, it's kind of hard to believe, right? Most doctors, gotta tell you, in medical school, it's what we're trained to believe. But there's a lot of healthcare that occurs outside the exam room. Most healthcare occurs outside the exam room. A lot of the most important healthcare occurs outside the exam room, and these are called social determinants of health. Life-enhancing resources, healthful foods, quality housing, economic opportunity, social relationships, transportation, education, healthcare. Distribution across populations effectively determines the length and quality of life. When I think about this particular public health law, I think about optimizing advantages for all people. And everybody can have the same advantages, by the way. There's really no reason to compete with each other. There's no reason why we all shouldn't have safe housing, safe neighborhoods, a decent education. We should all have these things, right? I think of them in terms of advantages or disadvantages. And there's certain things that become social determinants of health, by the way, that we don't always talk about. Some disadvantages, like student loan debt. That's a disadvantage, isn't it? You come out of school owing 6 figures of whatever, oh boy, that's a big problem all of a sudden. It changes your life. Changes a lot of your opportunity. You can't live where you want to live. If you're a physician graduating medical school owing $500,000, that's the price of a house. That's a problem, right? If you're a nurse owing $100,000, that's a problem, right? So these are things where there's other things that just affect the people's length and quality of life and how they can make their choices. Health disparities, though, is something that I think is near and dear to this audience as well, right? We talk about health disparities. Measurable differences. Health status, like access to care, quality of care is determined by race, ethnicity, sexual orientation, gender identity, preferred language other than English, gender expression, disability status, aging population, immigration status, socioeconomic status. Folks, life is short. We all value our life, but this is all about outcomes, isn't it? We don't want different outcomes based on these reasons. Life is going to hit you with enough curveballs. I can't prevent all types of cancer, and when it happens, it's awful. I can't prevent a lot of things, but I can prevent many things. But if we're all intentional about optimizing what we do with health equity, and if we're intentional about optimizing what we do with social determinants of health, we really might get to eliminating health disparities. All right, let's go on to some other things that we've done at the New York State Department of Health. Health equity is a cross-cutting work. One of the things the Department of Health did under Dr. Bassett was establish this Office of Health Equity and Human Rights. So we actually have this cross-cutting Office of Health Equity and Human Rights. And their sole focus, even though they're established in 22, is just to change the way the Department of Health operates. And hopefully we change the way other entities operate as well. Because it's really, the big point is, equity is not a distraction to our work. It is our work. This is what we do. It looks like a lot of different things, but it's really about driving home. We're interested in really making sure health equity happens. It won't happen unless we're really focused on doing it. There's some things we're doing to eliminate health disparities in New York. And I'm not listing everything, by the way. I'm just listing some things. But, we did increase Medicaid benefits last year. That's important. Our state, by the way, has a very generous Medicaid package compared to other states. You know, in certain parts of the country, it's amazing how poor people are but don't qualify for Medicaid. New York has a really diverse, broad package. We did a lot with expanding coverage. We are addressing social determinants of health. We've done a lot to increase access to behavioral health, still a big issue. And post-pandemic, it's one of those really big issues. It's interesting, as a public health physician during the pandemic, I worked at the Rhode Island Department of Health, but I also saw patients on Fridays in this practice in Connecticut. So every Friday I'd put on my sneakers, take off my tile, and have just a great time seeing kids. And one thing I can tell you, during the pandemic, I was prescribed way more Lexapro than amoxicillin. Really stressful pandemic for children. Really stressful pandemic for everybody. So people need time to decompress in the population trauma. You know, we are doing a lot with strengthening our data collection at the department. When I talk about hiring at the department, one of the things we do is when we interview anybody for a job at the Department of Health, we actually read them a paragraph about what health equity is. When we interview people at the New York State Department of Health for jobs, we ask at least two questions about their understanding of health equity. Part of what I'm trying to do is make sure when we hire people, it's a good fit. I don't want people working for us who don't want to be part of the health equity mission, because quite frankly, you won't be happy there. I want people to be happy at work. It's important, right? But this is one of the things that we're committed to do. We're trying to find partnerships anywhere we can to really work on health equity. We're doing a whole lot more. You know, workforce is something in particular I'm worried about, and we'll talk more about how that becomes something we can do to eliminate health disparities. And talk a little bit more about how we expanded Medicaid benefits. I think some of this is pretty well known to you. We authorize doula services, community health workers. I'm excited about the adverse childhood experiences screening. It's going to start January 1st. It was great that we could fund that in the budget, but a pediatrician will get paid $29 to do an adverse childhood experiences screening once a year. So looking for toxic stress in children. You know, it's not just because I'm a pediatrician I care about preventing toxic stress in children. It's just an important public health thing. But when you think about the trauma that kids go through just living their daily lives, this is an important thing to identify, get open in the exam room. Oh, the pediatrician can't prevent and solve most of them, but might be able to connect people to people who can. So it's just an important public health intervention we did. We're doing a lot with nutrition. We're doing a lot with arthritis self-management. And we're doing some rate increases. We did one for school-based health clinics. We did some benchmarking of primary care to 80% of Medicare. We did some ambulance emergency transportation increases. You know, we did a lot with reproductive health as well, and some things with supportive housing. You know, I was hoping today I would talk to you about 1115 waiver that was approved, it was done, it was signed, sealed, and delivered. Just not the case, but that's okay. Give you a little broad brush of what's in there. But the 1115 waiver is big. It's in the billions, so it's okay that it's taking a little bit of time to get the numbers to be just where we want them to be and assume all of our variables are addressed. Some of them have been changing recently. You know, but really the goal of the 1115 waiver is to advance health equity, reduce health disparities, and support the delivery of social care. And the Department of Health is in the final stages of this. Same with our 1332 waiver, by the way. And we can reach this goal, you know, through population health and health equity improvement, you know, with envisioning a new primary care model, which not just us looking at this, Center for Medicaid and Medicare Services looking at that too. A lot different about how primary care should be and will be. Hopefully we can find primary care for all people someday. I think that's one of those things that we don't talk about often enough, is that how healthier would we be as a nation if everybody had a primary care provider and it was normal? And it just seems like that's something we need. And doing a lot to provide the social care network. This 1332 waiver, you know, that is going to be approved soon, I hope, as well. I was hoping that would be something we could talk about today, that it was done, but it's close. But it's going to hopefully, you know, expand coverage to people at 250% of the federal poverty limit. I think that will help quite a bit. Right now, there's 1.2 million folks enrolled in the Essential Plan. You know, as we've done our transition during the public health emergency unwind, we've seen some more people come into that, which has been helpful, I think. You know, and many of the Essential Plan members have no premiums, no deductibles, very low out-of-pocket costs, you know, really helping this social determinant of health insurance allow people to have access to care. So we're expecting, if we do get our 1332 waiver approved, that it would extend affordable coverage to near 100,000 more eligible individuals. And I'm hoping we'll get this information soon. Our current timeline is for it to take effect in April of 24. So more to come as that happens. Just going to highlight a little of what we talked about in behavioral health, just so you have a little bit of visibility on that. Most of it started with this billion-dollar investment, but there's a lot of work that we need to do with the Office of Mental Health to improve behavioral health in New York State. Not just expanding psychiatric, comprehensive psychiatric emergency room programs, but expanding treatment programs, certified community behavioral health clinics, home health programs, and really increase rates for school-based health clinics. And I'm a big fan of school-based clinics for a lot of reasons. I think, it's another example of a partnership between pediatricians and schools. I think kids like being seen the same day they have a problem, being addressed somewhere where they know somebody and don't have to miss school for that. It's a very nice little synergistic model that we've got that we're trying to improve on. We are doing a lot to improve data collection here. A couple examples are just improving data collection through the marketplace. We're making some changes to the marketplace application questions to require response to race ethnicity queries. Part of the issues with that is people haven't been disclosing data, so we don't know what we don't know. It's hard to fix data when you don't know what you don't know. With health equity impact assessment, as of June of 23, certificate of need applications need to do a health equity impact assessment, which is, I think, a really vital way of, if we're going to do something somewhere, making sure we've looked at the community and make sure we have the community's needs addressed, and we're thinking about this. So it's a very intentional effort, the health equity impact assessment, and I think it's really something different that other states aren't doing yet. I'm going to talk a little bit briefly. I think it's well known. We did a lot in the budget last year to help hospitals. The increase in Medicaid was, quite frankly, historic. It may not be what everybody wanted, but quite frankly, it was a historic increase. And when you look at how much we did for nursing homes, again, these are huge increases. Oh, I know it's not what people wanted, but it's what we could do. And we can talk a little bit about maybe some ways of solving that without always giving more. I think sometimes we need to think about how do we lower costs for hospitals and nursing homes? Because I think in the long run, helping them lower costs are going to help us, as opposed to keep constantly giving more and more. Other things we did was a $1 billion multi-year healthcare capital program to drive transformation healthcare investments, including $500 million we just announced to support investments in technology and cybersecurity. Isn't that interesting how big of a problem cybersecurity is being? Tough time to be a hospital when you're dealing with cyber attacks daily. That's just tough. So I think coming out with regulations that we just put forward, we're looking for public comment on that. Please weigh in on that. I love public comment. I think it makes regulations better. And I think it's one of those things where it's like, we did regulations with money, so we're telling you what to do, but we're giving you tools to solve it. Helping people, hospitals in particular, the smaller ones that are going to need the help to kind of put their systems up. Because if you protect hospitals, you protect their patients. And then all on top of this, $950 million in statewide forward, which is coming out soon as well, so hospitals can do some of that transformation work. Other things I want to just touch on really quickly is workforce challenges. And if there's one thing I've just learned in my time back in the state is we're different than other states. I've traveled the world. I've seen it, and I've traveled the country, but we are different than other states. And sometimes different is good, and sometimes different is just different. 49 states allow a medical system to administer a vaccine. We don't. Well, that's interesting. Why is that? We're the only state in years that requires a nurse to get a Bachelor of Science in Nursing in 10 years. And since we're 46 in the nation, with nurses passing the nurse certified licensing exam the first attempt, no difference between an associate's degree and a bachelor's degree, I just wonder, why is that we still require this, Keep in mind, I was away since June of '86, just come back in June of 22. I was trying to come back, it just took a while, but I just noticed things are different here, right? We require a lot, by the way, of physician assistants. It's kind of interesting. We don't just require them to be supervised, we have ratios, and it's just interesting how much we require of physician assistants. We require them to have a physician's name when they do a controlled substance prescription. We don't even let them sign a prescription for durable medical equipment. We're different in other ways than other states are. And we should always think about, why are we different? Because sometimes if we have issues that we're not happy with, we should say, well, where are we different and why are we different, right? How do we look at anesthesia in New York? We're the only state that doesn't license certified registered nurse anesthetists. Why is that? And why is it that we haven't embraced the notion of anesthesia assistants that other states have looked at? Oh, we have anesthesia shortages. If you look at what's contributing to maternity deserts in New York State, Sometimes they just can't get anesthesia at an affordable price for the hospital. And sorry to say it's an affordable price, but anesthesia is in such short supply, they're doing what other people did during the pandemic, which is bidding up services. There's other physician shortages there too. Oral health is a problem, by the way, in New York. 600 million teeth call New York home, by the way. That's a lot of teeth to call New York home. But I don't know if it would surprise you that if you're an adult on Medicaid, 4 out of 5 adults on Medicaid haven't seen a dentist in over a year. That seems odd. Over half of the children who have Medicaid haven't seen a dentist in over a year. If you have dental insurance, it's hard to find a dentist who takes your insurance. I noticed when I came to work for the state, I have dental insurance. Took me a while. I'm just saying we need to look at oral health a little bit differently. Other states have done some things about that. They look at dental hygienists and say, not every dental hygienist needs to be supervised in every situation. Some states looked at dental therapists. These are interesting ideas. We should look at these ideas. And we've looked at license compacts a little bit differently than other states have, haven't we? 41 states thought a nursing compact was a good idea. Not us yet. 39 states thought a physician licensure compact was a good idea. Not us yet. So that's interesting, isn't it? And I think one of the things I see with hospitals in particular is, nursing homes as well, it's really hard to run any kind of business enterprise without having predictable labor costs. And it's hard to do that during the pandemic. One of the things you saw during the pandemic was the agency contract staff. I was talking to one hospital system said in 2019, before the pandemic, they spent $19 million a year on agency contract staff. In 2022, they paid $260 million. That's just an enormous difference. So I think we really need to look at how can hospitals survive if they're constantly paying so much for agency contract staff? They're just not going to be able to survive the way we need them to. So workforce capacity building is something we're doing at the department, doing things that we can do. We're trying to help with training. We're doing some things. We have some money. But I think one of the things we really look at, what is the health policy in the state regarding workforce? Can we look at changing things in our state and maybe make workforce a little bit more like other states? I think we need to be thoughtful about how we do this. And I think it's important to look at some other topics too. I talked a little bit about the public health emergency unwind. I think many of you are very familiar with this. New York, I think, has done a very good job with this. We're trying very hard not to see people become uninsured. We're trying very hard to help them renew their insurance. We're trying to help people either stay in Medicaid, but if they can't, try to move them over to the essential plan. If they found a job and got commercial insurance, God bless America, that's great for everybody. But we're trying to make sure people don't have a problem where they're uninsured. Because we know when you're uninsured, it's just hard to access health care. It just really is. And I want to end with, I do think we want the same things. As we get to this, I want to beg a question to you, though, is do we have a healthcare system? I would submit to you, no state in this country has a healthcare system, and that's not a criticism. It just is the way it is. We have a healthcare marketplace, don't we? But what we want, I think we want the same things, right? I want the direct patient care experience to be safe, affordable, high quality, accessible. By the way, I'd like it to be enjoyable. I'd like it to be personal. I think you want the same things too, don't you? But there's only so many dollars, right? Every dollar we spend on direct patient care isn't a dollar I spend on roads, bridges, schools, housing, other things that people need that are social determinants of health. And you must be wondering at this point, did he really put a picture of Humpty Dumpty up there? It's early in the morning and I had coffee, but is that really Humpty Dumpty? It is. It's okay. Talk about why Humpty Dumpty is enjoying your coffee this morning with you, right? But one of the things about healthcare in the United States is we do spend a lot of money funding all the king's horses and all the king's men. But they didn't put Humpty Dumpty back together again. It's really hard to put an egg back together, right? So I'm the public health physician. I don't need a lot of money to tell Humpty Dumpty, dude, you're an egg, you have no business sitting on a wall. If as this egg monarch you must sit on a wall, I'm gonna get you a harness, I'm gonna get you a pad in case you fall, because I can see what can happen. One of the things about public health physicians is that we look to the future, we anticipate. We can look at a circumstance and say, here's what we see is going to happen. We're not reacting to problems, we can predict them. Proactive is what we are. But I would submit in the United States, we need to look less at all the king's horses and all the king's men and finding ways to fund the people who have the courage to tell Humpty Dumpty, you have no business sitting on a wall. All right. I don't know what it could look like from your mind, but I'm going to end with this inspirational side of what it could look like. I've told you I've been a lot of places. One of the things I will say, though, is it's interesting how much the Indian Health Service influenced me. The Navajo culture influenced me a lot. I learned a lot about just how to be a kind person, how to see there's a larger point in life, and how to recognize a lot about the planet around me. I learned a lot from the Navajo. But one of the things I saw when I worked for the Indian Health Service, which is kind of interesting, is You know, when I worked at Indian Health Service Hospital, keep in mind, the public health service had been there 50 years before I got there. The health literacy rate among the Navajo was humongous. Never had a patient walk in my exam room saying, "Doc, I need an antibiotic, I got a sore throat." Never happened. Never had a patient walk in my room saying, "Doc, I need a CAT scan, I got a headache." Just never happened. What I heard was, "I have a sore throat. I have a headache." But also, what was interesting was what was under the same roof. Like I worked at an Indian Health Service hospital. It was interesting what was under the same roof. Primary care was under the roof. Specialty care was under the same roof. But here's where it got a little bit different. Mental health care was under the same roof. Dental was under the same roof. Oh yeah, there was a hospital under the same roof too. And it was all one floor, by the way. Big building, right? But here's the part that amazed me the most. The largest part of our Indian Health Service hospital was the public health department. Huge number of public health nurses, and they had a lot of Jeeps driving on their dirt roads going everywhere. Out in there, you know, just saying, it's like, it's just interesting how it was actually a health system, by the way. Like, it was called the Indian Health Service, but it's really a health system. Because no matter who you are, you're eligible. No matter who you are, you can get access to care. And even if we couldn't provide the care in our hospital, we could find a way to get you through a contract somewhere else. It was a health system. I don't know if the United States will ever get to a healthcare system, but it's worth shooting for. And I didn't say it was going to be done through single payer. I'm saying it's possible we can do this other ways. And I think that's just an important thing to think about. So it's traditional this time to ask if there's questions. And I think I probably ran over a little bit, but Eric assured me, "Jim, you're the commissioner. They'll want to hear what you have to say, but they might have a question or two." So as you're getting ready for your questions, let me let you know about our new podcast, and then let's see what we have to talk about next. It's not, but you can use this one.
I appreciate that. How about we share? So thank you again, Commissioner. We appreciate your time. As a reminder, through the app, you could submit some questions. We've got time for maybe one or two questions. I've seen a couple, pop in. Commissioner, one question. You talked a bit about mental health, the priority there. I think to paraphrase one of your your last slides here, we want the same thing. And can you give some perspective to our industry, particularly the health plans, as to we've been working to try and partner with our partners in the provider community. I think we want to make sure that folks are getting the services they need. Can you give a little perspective about maybe the best ways to go about working with the department and other state agencies in a collaborative approach to achieve our mutual goals?
Yeah, so I'll say this, as far as mental health in particular, let me give you a couple short-term things. Optimized number of people end up in the essential plan is probably very helpful, helping people enroll there so they have health insurance. I think that matters a lot. I think one of the things we need to be honest about, though, is that there's just a shortage of mental health providers and mental health beds. I think that's something we have to say, well, that's the workforce issue. I talked about that. I'd invite you to think a little bit more broadly, though. This is how I think, too. I think mental health problems might be preventable. Some of them are, at least, right? I think one of the things we do is how do we address children's health in New York State? Here's where I'm telling you something you didn't see coming, right? I'm concerned about how we funded earlier intervention in New York State. I practice like a lot of states. I've never worked anywhere where there's a wait list for early intervention for kids less than 3 for healthcare. So that stuns me that we have a big wait list for early intervention. I think it's important to help children earlier in their life to help solve their developmental concerns. I'm excited about the ACEs screening we're doing, because if you can help to mitigate toxic stress, I think that does a lot. I'm interested in helping hospitals open up more psychiatric beds too. I'm kind of hopeful that as medicine progresses, you see more and more cool vaccines coming for kids. I'm not trying to oversell nirsevimab by Beyfortus too much here, but if we didn't have the supply and demand problem, I'd be more optimistic about this, but if you can actually get kids to not be in the hospital for RSV, hospitals might need to find what else to do with those beds someday. That's my optimistic part of me. And part of what I'm getting is it's not one solution, but if you're thinking about today as a health plan, how do I partner with V.McDonald, Commissioner of Health, trying to help everybody? Help me get more people into the essential plan. I think that would help a lot. Thank you.
So one more question, I know we're going to move on to our next panel. Our next panel that's going to be coming up is going to talk about how to empower patients to improve their health. One question for you is, we know there's some significant fiscal challenges that the state's going to be facing.
I've heard.
You've heard, I'm sure. Public health is always a challenge as far as trying to provide additional investments. Can you give just a little perspective to approaches that you'd like to see, maybe public-private partnerships for initiatives that are going on where
our industry or others in the healthcare sector should be looking to partner either at the county level with the state, to make sure that despite whatever fiscal challenges the state might face, we're still able to provide to make those investments.
So I think the main thing we can do to address some fiscal challenges, we need to help hospitals and nursing homes lower costs, because quite frankly, sending billions of dollars every year to help hospitals and nursing homes survive just isn't sustainable for the state. So we need to focus on helping us have hospitals lower costs. I think it's really critical. I think partnerships with local health departments is long overdue. I can tell you local health departments aren't here today, but Sarah in Ravenhill from the New York State Association of County Health Officers is. And I can tell you any local health department would love to partner with you on achieving some of their goals and metrics. I'm sure they would find your interest welcome and helpful. I think when you look at the 1115 waiver in particular, you're really going to see an emphasis on social determinants of health. This could have the effect of reframing how we think about healthcare, in New York, because really looking at not just what's wrong with you, but where do you live, how do I help your life outside the exam room actually be a life that promotes health and wellness?
Well, we appreciate that perspective, Commissioner. Thank you again for taking the time. Please join me in thanking Commissioner McDonald for his time.
Thanks, Sarah.
Thank you. We really appreciate it.